All right, we are back for another Thursday series. I've got a new camera incoming, so hopefully everything will be faceless just for a little while longer. But we've got several studies on the docket. I know I say this every week, but it is going to be fairly quick. There's not too much to say other than what these studies said when they cross my feed. So let me clear my throat, take a drink. First one, observational study of safety of chiropractic versus medical care and medical care with or without prescription medication. Not too much to say other than almost 300,000 patients were analyzed. They were either put through CMT, chiropractic manipulative therapy, pharmacological management, or primary care only without prescription. And basically, once again, we have a lot of studies backing up that chiropractic care is in general safe, especially when you rule out for other comorbidities and other factors and you screen your patients appropriately. Not surprising, and again, this is specifically for Medicare Part B beneficiaries with neck pain. Chiropractic care is associated with the lowest rates of adverse events in versus primary care. Primary care without medical prescription was next lowest, and the highest rate of incidence or side effects was found in the prescriptive medication group. Not too surprising. This is just, once again, something that I don't need to speak too much of. Just want to show you the studies that just keep compounding. So let's move on to the next one. Effectiveness of backward walking combined with conventional rehab for managing knee osteoarthritis. So there was a study that showed backward walking could help improve or be included in a low back pain case, acute or chronic, just because it changes your center of gravity and that gets some different postural muscles to work. But now it looks like we may have another reason to integrate walking or backwards walking in addition to rehab, because the way that your body goes through that program movement apparently appears to have beneficial effects on knee osteoarthritis. Oops. So what were the results? Well, 13 randomized controlled trials combining backwards walking exercise with conventional rehab found to significantly reduce pain intensity and improve disability. It revealed larger effect sizes for comfortable walking speed and treadmill walking. Significant differences were observed across all control groups for comparison. So this is just something that if you follow my Instagram, you would have seen that I tagged a couple of studies and a couple of people talking about walking for low back pain. We found the study last week in regards to walking for low back pain and now backwards walking for knee osteoarthritis. So once again, the studies are continuously showing various forms of movement and exercise are some of the best things that you can do for a majority of your chronic painful conditions. So even if they don't cure it, boy, do they help. So let's keep you guys moving. Now, manual therapy reduces pain, disability, and oxidative stress in patients with chronic, non-specific neck pain. A double-blind, randomized pilot study. Well, what on earth are they doing? Like, we see manual therapy, but what do you mean oxidative stress? Well, they wanted to measure this marker right here. So oxidative stress is assessed using a blood serum lipid hydroperoxide. And they wanted to see if manual therapy had any effect on it because they would use it as an adjuvant marker to associate manual therapy with either reducing or not reducing overall oxidative stress. Because they can also associate that oxidative stress with various things like inflammation and painful conditions. Now, again, it is a marker and it's not telling the whole story because there are it doesn't have to be if you have high oxidative measurable stress, you're in pain or not in pain. This is just a proxy measurement, okay? So let's keep that into consideration right now. So what did they find? Well, once they went through and did the study, manual therapy appears to affect those serum oxide measurement levels in chronic, non-specific neck pain patients. So pre-intervention, mean levels for those neck patients were 3-fold higher compared to those with healthy individuals. So following 9 treatment sessions, they seem to regress to healthy levels. So basically the control group, They regressed to the same levels as the non-painful control group. Now, they also had a sham group going with this one. So the oxidative stress levels of patients following a sham intervention only decreased by 0.7-fold during the first treatment session and remained unchanged even after 9 sessions. So sham didn't seem to do anything, which tracks. Let's see, what else is big about this study? Oh, and when we're talking about manual therapy, I almost forgot to mention this in the objectives. It includes low velocity, low amplitude, or high velocity, high amplitude manipulative therapy. So that's actually going to be a big piece of the little bit that I wanted to talk about at the end. So why is that important? Well, what the heck, I'll skip right to the end. The conclusion that they came to is that rather than just saying manual therapy in general, it specifically subclassified HVLA and LVLA manual therapy reduces pain and reduces oxidative stress levels and improves function. That's important because a lot of studies will pick one or the other. And if you don't know what those are, it's essentially either HVLA, which is the classic chiropractic adjustment, which is the high speed. You actually will try and get some, take the joint to end range, give a quick impulse and back off. It's also called sometimes a grade 5 mobilization, or a low velocity, low amplitude. So much, much slower. This is in terms of mobilization. So somebody's just taking the joint through a comfortable range of motion, but still typically going all the way through to the end, trying to get some additional movement in the area. And it appears that both, yes, both, not one or the other, both can reduce pain in these chronic neck pain patients, which tracks with what I've seen in clinic, because a lot of people are hesitant about getting their neck adjusted. Now, I'm not going to sit here and have an hour-long diatribe on, everybody could use it or not. Is it, there is no risk, or is there all risk, catastrophic risk versus, well, all I will say is this, is that there is a lot of hype out there on the internet and on social media just because it is a sensational treatment in regards to, it can be very showmanshipy, and as it can also be very, it can get a lot of clicks and get people a lot of attention one way or the other, either pro-adjusting or anti-adjusting because of the associated potential benefits and associated potential risks. But if we're not sticking to the sensational aspect of neck adjusting and we just take it at face value for the evidence, as long as you're screening for the right patient for the right condition, it is an extremely safe intervention, which can be used for things that can include nonspecific neck pain, chronic neck pain, some dizziness episodes for cervicogenic vertigo. So it does have a very appropriate time and place, but it is by no means the only intervention that can work for these things, which this study is backing up, because now you can use low velocity interventions as well, which, for some patients is much preferred, because despite all the evidence, showing safety, there's still the patient comfort aspect and the patient-centric approach that we need to take when it comes to developing our interventions. And so if you have a lot of patients, for example, like mine, that don't like their neck adjusted, one patient actually comes into mind in particular where this individual came to us last year, had myriad of different things that she wanted us to work on, and she was fine about, in her words, cracking her like a glow stick everywhere else except for the neck. And you know what? That's absolutely fine. We can respect that all day, and she still received a ton of benefit from us doing the LVLA that's mentioned in this study, because it's what she was comfortable with and what we know has benefit in her specific conditions. So this is mainly not to show that, blood serum levels, adjusting, manual therapy, they're all, you can demonstrate and track and do all these sorts of, no, this one, it's just to show that while, yes, I am a fan of the adjusting things, I enjoy it in various parts of my body for different conditions, aches and ailments. You can certainly get away with low velocity stuff, whether it is, HVLA is contraindicated or the patient is just not comfortable with it. One sec, I still haven't fixed this issue. So I love things like this that give us multiple options for patients when it comes to taking care of them and what they're comfortable with. Now, moving on. Instrument-assisted soft tissue mobilization, something we do a lot here, and percussion massage therapy in cervical disc herniation, randomized controlled trial. So what did they try and do? Well, they tried to add these interventions into study arms to conventional therapy. That's got to be the key here. It was added on top of conventional therapy for people suffering with cervical disc herniations. And what they found is while all groups benefited because the conventional therapy works, it seemed to be that the percussion massage therapy, ergo the, think of it like anything like a hypervolt or a Theragun, and IASTM produced greater improvements in pain, fear avoidance behavior, and what was JPS again in this study? Give me one sec. Oh, joint position sense. So how well the person was able to perceive where their body on a joint level was at any given point in time, which is correlated with some chronic pain conditions. So this was fantastic that they were able to improve not just pain, not just a fear avoidance behavior, but also that their body seemed to be more aware of the joint structures and then could, in theory, bounce back quicker or better than the control group. So that was something pretty neat, just to see that something that we do in the office already for people suffering with conditions that can include cervical disc herniation is showing to have research benefits backing up what has been clinically seen here, and that it just seems to help the patients get through whatever they need to get through, reduce pain, get them to actually do the movements that they may be scared of, or get their body more aware of where they're at any given point in time to help further rehab results. Now, we've got 4 more studies, so let's just keep knocking these out of the park. High energy, focused, extracorporeal shockwave therapy in the treatment of lumbar facet joint pain, a randomized sham controlled trial. This is one that we've essentially reviewed before, but it's just another study saying the exact same thing. And what I like is that we have practitioners around us that have these devices, which means if I'm able to find this and diagnose this condition, in addition to what I already offer in my office, this can be something that can greatly improve the quality of life with these patients, just working collaboratively with other nearby healthcare practitioners. So I really like this. Let's just review it again. Randomized sham controlled trial done on 128 patients confirmed to have a lumbar facet syndrome via a medial branch block. They received either extracorporeal shockwave therapy or sham therapy. Basically, the thing would just make sound. And they wanted to see, hey, where were they at 2, 6, and 12 months in terms of pain, disability, and neuropathic pain features? Well, the intervention group, the one that actually received shockwave therapy, had significant reductions of their pain scores at long-term check-ins at 6 and 12 months, a roughly 64% reduction at a year mark with an effect size compared to, here it was, compared to 12.5%, or sorry, I'm jumping the gun. Their disability scores decreased by 42% in the treatment group versus 12% in the sham group. Neuropathic pain symptoms improved significantly only in the group receiving the intervention. So that is really, really neat. One more thing, MRI follow-up demonstrated resolution of bone marrow edema. So think of it as inflammation of the bone going through a stress response, an injury response. It showed that it cleared up in a majority of the extracorporeal shockwave treatment patients versus none in the control group. So once again, if I didn't have practitioners that were so close that could actually utilize or that actually do utilize this therapy, this would be something that is very high on my ticket item to get in the office here. But hey, such is life, and it gives us more of an excuse to work collaboratively with other people, so I shouldn't be complaining as much. They get the toys, I get to refer them, everybody gets better overall. Now, last 3, manual therapy and exercise targeted to the neck and oral facial regions for patients with oral facial pain. Put another way, we're looking at TMJ and TMD, temporomandibular joints and temporomandibular dysfunction. Actually had a case of this last month. And this is exactly what we did after a little dental incident this person had, where he developed secondary TMJ or TMD as a diagnosis, temporomandibular dysfunction. So what did they do? They took a look at 37 studies. Admittedly, most of these had a high risk of bias. Therapies such as manual therapy alone or combined with exercises targeting both the neck and jaw improve pain and tenderness. Manual therapy and combined treatment targeting only the neck were clinically relevant for pain relief as well. So really, it comes down to something that I've talked about a lot before. You cannot not include the neck when you're looking at a jaw. They are intertwined in a lot of what they do. They're interweaving muscle insertions, actions. There's position sense. There's a lot of things to consider. So if you decide to take out entirely the neck, you're only taking a look at part of the picture, and your patients are only going to get so much better. So it's something that we do in the office. We just had a case of this last week. And if you are suffering with a TMJ issue and your provider is not looking at the neck, look at the neck. If they are jumping the gun, going straight into pharmaceutical interventions, those are not really recommended for a lot of what well, obviously for what I see in my office, but a lot of what I see in general from a public standpoint, as far as pain goes. And we should be considering some form of physical rehab intervention combined with manual therapy that addresses both regions, the jaw and the neck, to actually give these patients a fighting chance so that they don't jump the gun and go into a surgery that has a very poor prognosis. TMJ surgeries are very, very, very hit or miss, and you really want to make sure that all other avenues are exhausted first, because they are such a toss-up as far as results afterward. So that's my little spiel and piece on the jaw for this week. Last two, almost done. Concurrent validity of directional preference compared to controlled lumbar discography, a supplemental analysis of diagnostic accuracy. What is this? Well, it's basically those people that suffer with lumbar disc issues in particular. Shows that if you know what you're doing, putting a patient through a controlled movement analysis can really help when it comes to diagnostic accuracy. Okay. It has limited screening ability. So if you don't even know if they have a disc issue, it's a toss-up. If you know they have a disc issue and you've confirmed it with other diagnostic tests, having a low, what's the word I'm looking at? A low tier intervention and a low cost diagnostic intervention for accuracy is amazing. Okay. It is amazing. It is something that we will do, in the best way that I like to describe this to the patients is, if your back, for lack of a better word, is a jumble of knots, whether it's a shoelace knot, cords, whatever you want to think of, this is kind of giving us an idea of which string to pull at first to start loosening up the jumble of knots to get you back to doing and moving the way you want to move. That's the best way that I can describe it in a short sentence. And it's really all we need to know about it. There's no magic to it. We're not moving disc tissue. We're not doing anything else. We're just finding an acceptable pattern of movement that the body can tolerate at this time when everything may be going under DEFCON 1. And it gives us an avenue and approach to start to rehab the patient in the safe direction and start to loosen up the other proverbial knots. And I like to see that being able to back up what we do with a strong diagnostic accuracy, to me, is just icing on the cake. Okay. It is by no means the only thing that you can do or should do, frankly. You should be backing up multiple low intervention diagnostic tests to add validity and accuracy to what you're doing. And you don't always need to jump to MRI. Now, we can always have fun where, if you have neurological deficits, if you have significant impairment or other issues that I'm thinking there's a higher level lesion in there, I could do this quick. Figure out if there's a direction. And hey, look, I can also send you for an MRI because you have those neurological deficits, which to me, depending on their severity, could indicate a, proceed with caution, yellow light, like monitor it, or red light, like, no, that's too sudden, too quick. That's a lot of deficit, or that's a lot of scary things happening at once. You do get to jump to MRI. So this is something that we play with a lot for the patients that we suspect have a disc issue. Okay. Now, last one. Relative contribution of real versus sham spinal manipulative performance, changes in cortisol levels, and patient expectations and fear avoidance behaviors, and modulating short-term pain relief in people with neck pain. A secondary analysis of a randomized controlled trial. So this one, what a mouthful. Similar to the HVLA versus LVL, a paper that I mentioned a couple of papers ago. This one is fun, because this, more than any of the other studies, really tells us what we're doing at the clinic is on the right path, and it reinforces what I already do with patients. What do I mean by that? Well, here, let's just read the highlights first. Positive expectations enhance immediate analgesic effects of spinal manipulation. So wait, you're telling me spinal manipulation is a placebo? No. Parts of it are, though. Is the whole thing, is what I'm saying. So is the whole thing placebo? Not necessarily. But I cannot in good conscience say that none of it is. And that's okay. I love that, actually. I'm going to get back to that fact. I want to keep reading the highlights. Salivary cortisol changes are not linked to short-term pain intensity changes. So basically, they tried looking at a similar biomarker. So rather than in the blood, seeing if there was oxidative stress, they tried to see if there was salivary cortisol changes linked to adjusting. There weren't. Who cares? Frankly, in my opinion, fear of spinal manipulation does not significantly affect pain intensity changes for patients going through trials of care, and real spinal manipulation reduces pain more effectively than a sham performance does. So for me, this one and this one, I'm going to talk about a bit, but mostly this, because something that I've seen, something that I know other clinics do, and something I've seen in other bits of research really, really, really reinforce the patient expectations, setting up a proper prognosis and clear objectives has a huge benefit on patient care. Put another way, if two patients have the same exact diagnosis, the same exact interventions, the same exact everything, but you actually take the time to educate the patient on their condition, set up realistic expectations of what should and should not happen, and give them a timetable to operate on, several things happen. One, they're more likely to trust you as a provider. Two, they're more likely to actually get better throughout the trial of care because they know the ebbs and flows, what to expect, and how things should trend, which means they're going to follow through with additional recommendations, be more compliant, and have the best shot at actually getting better. And I had a third and, what was it? I think I said it in the second one. Compare that to the person not getting any of the education. They may not know what to expect at any given point in time, which means they're not as likely to go through with the same level of compliance. They may drop out of care sooner, and they're the ones that will say a certain intervention or therapy did not work, or the provider did not work, or something failed in their trial of care. And a lot of that, all of that really is effective communication, setting up realistic expectations and prognosis. I mean, I can't tell you how many times a patient has walked in saying, hey, all I need is, crack me like a glow stick and I'll be fine. No offense. That is up to me and us, not just you. Like, you don't walk into any other doctor's office and say, hey, yeah, I just need that medication, or walk up to an oncologist. Hey, yeah, between all the potential interventions for this cancer, I need this. No. To be effective in tackling any of your issues going on, it is a collaborative session with your provider, and having them actually set up what is realistic is going to be your best shot. Not the, all I need is this, you happen to get it, and it doesn't work, now what are you going to do? So having an office and setting up my practice where I can, for each and every single one of my patients, set up actual expectations where I can tell them, hey, this at this stage is going to get better. This at this stage is going to get worse. I have had so many patients come back to me and tell me, wow, yeah, you were right about all of it. I understand what you're saying, and I'm ready for the next steps. It is so personally rewarding seeing the extra effort pay off on the patient's end for them to get better, that I will not go back to doing 5 or 10 minute sessions because I can set up these things without feeling like either one of us is rushed for each one of my patients. I can set up the necessary education. I can set up the realistic prognosis of the entirety of the condition itself. Like, hey, yeah, you just had a non-traumatic, knee meniscus tear show up. That's going to be more than just a few days care. Like you have to take a look at it as a picture over months, to couple years, setting up different lifestyle factors and understanding this whole condition. It also lets us set up realistic expectations for various forms of treatment. Like, hey, here's the pros and cons of each treatment. If I were in your shoes, I would get treatments instead of A, B, C, and D. Let's do treatment, A or A and B because they work well together. See if they work and tell you the realistic timetable of they should work over this time frame. If they don't, we'll be able to switch. And it really lets us play quarterback in a way that I feel I would have always wanted as a patient on the other end, because there's so many things that you have to juggle with nowadays, between so many different providers, so many different conditions, so many subspecialists, so many potential accesses to higher level interventions that may or may not be warranted. I cannot in good conscience practice any other way than I am. And having studies like this where even if every other provider is the same, doing the same thing, hey, spinal manipulation, having that positive expectation set up on the part of the clinician for the patient enhances the effects is so cool. It really is just so cool. And it's one tiny piece of the puzzle in this greater study, but what we're able to extrapolate from that and how we're setting up what we do here at the clinic is just so reassuring. I love this stuff. And I hope this little end of the video ramble ramps you up to, like, just get excited for these sorts of things. But like I said, I've spoken long enough. Thank you for sticking with me this far, and until next week.